This conference will now be recorded.
So welcome everybody on December 30th, the last meeting of the year, the last advanced recurrent and high-risk prostate cancer meeting of the year. And it's great to see such a good crew. We've got already 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We've got about 12 already, and we've got at least 2 more people that we hope are going to join us. So that's pretty good for the end of the year. Let me do a quick run through just to make sure I've got everybody's name. Rich Jackson, Alan Moskowitz, Ken Anderson, Carl Foreman, Len Sierra, Les Shelderup, Joe Blanchett, Larry Fish, Jake Hannum, Jim St. James, Dennis Correa. Did I miss anybody? Okay. Because last time I did miss someone and they didn't pipe up. And then I was very embarrassed towards the end of the meeting. So,
hey, Rick, you did miss me tonight.
Okay, thank you. How'd you like that snow on the mountains, Mr. Correa?
Beautiful.
Yeah. Ours has melted. I don't know about yours, but it's gone down here. We don't have anybody new. We have one person that I know has something to say and can only stay with us for an hour, so they will get promoted. And again, just remind me if you have to leave early so that we can make sure that we get you in. And let me run down the list. I know that the 2 folks that are joining later, both of them have stuff that they will want to talk about. So we will, when they come on, we'll receive them. So let me start with Mr. Jackson. Mr. Jackson, anything that you would like to talk about this evening?
No, we're doing fine, thank you.
Okay. Alan, I know you would like to say something, so I've got a tick by your name. Ken Anderson, anything for you tonight?
No, I'll just listen in, thanks.
Okay. Carl, how are you? Anything you'd like to speak to us about tonight?
Good evening, gentlemen. Yes.
Okay. Len, anything for you tonight?
Not tonight, sir.
Okay. Les, anything that you'd like to talk about tonight?
Just a quick one, yes.
Okay. Joe Blanchett, anything that you'd like to discuss tonight?
Yes, I need about 5 minutes or so. I also have the answer to the 2 questions you asked me to ask Dr. Anthony Marcus.
Oh, great.
For you too.
Super. Okay, you got it. Mr. Fish, have you been eating too many potato latkes?
No. Thank you for asking. And
Just checking.
still relatively happy sitting here in limbo.
Okay, so nothing special that you want to talk about?
Nothing comes to mind in a minute.
Okay, Jake, how about you?
Nothing for me, thank you.
Okay, Jim St. James, would you like to give us an update?
Yeah, I've got a couple questions. I started Zytiga.
Hold on. We'll come to you, Jim. What I might do is wait to talk to you until Peter arrives. Peter's called us and said he's going to be a little late because he's coming back from an eye doctor's appointment.
Oh, okay.
So
nope.
If it's okay by you, I'll wait until Peter joins the call to come to you. Is that okay?
Okay. That's okay. I'll go back to mute.
Okay. Thank you. Dennis, anything for you?
No, thanks, Rick.
Okay. All right. So let's start with Alan, because I know Alan has a time constraint.
Right.
And tell us what's on your mind, Alan.
Okay. So I'm going to ask for some thoughts on next steps for my situation. Here is just a very brief background to get everyone up to speed. I had prostatectomy in early 2013. I had good pathology, Gleason 7, 4+3. Nevertheless, I had a recurrence. And in 2016, I had radiation to the prostate bed, along with 6 months of concurrent hormone therapy. And then after a period of time, PSA kept going back up. And so last year in May, I went down for a clinical trial in NIH with a PSA of 0.5, ran the trial with a PSMA scan, and there was no cancer found. And so PSA has continued to go up with a doubling time of roughly 10 or 11 months. My medical oncologist at Sloan, who I'll see again in 2 weeks, has said, okay, just keep an eye on it, and would consider me for hormone therapy, assuming the doubling time doesn't pick up speed, and a PSA of somewhere between 4 and 10. Nevertheless, with his blessing and also with the blessing of Dr. O at Mount Sinai, I had an Axeman scan last month with a PSA of about 2. And most surprising, they did not find anything. And I actually got a disc of the scan, and I flipped through it ahead of getting the report. Some cases, you can't get the report directly. It has to come through the physician, the ordering physician. And so while I had that scan one night, I flipped through it, and I could see some areas glowing right around the prostate bed. And I said to myself, aha, here is where the cancer lies. Well, when I got the report, I was surprised because even though those areas were glowing, they were glowing due to inflammation, not sufficiently glowing to prostate cancer. And I spoke to the radiologist directly. He answered all my questions and assured me that this is very common in people who've had radiation. You will have some residual inflammation. So that's where I am. My PSA is 2.1 now, actually. And the question is, if my next scan is going to be back to a PSMA scan, at what PSA do I pull the trigger on that? I mean, I'm sure I can find a scan, a clinical trial somewhere. I'm not overly concerned about it. But the question is, do I wait a year? Do I wait to PSA 3? Do I wait to PSA 4? I mean, I think this is my last shot at doing the PSMA scan. And so, again, my motivation for doing it is just to see where the cancer lies. And if there's any chance that I can have it radiated, in other words, if it's not in that prostate bed, or if it's somewhere else that could be treated in some way, that's my motivation. And if I find out that the cancer is in the prostate bed and I can't do anything about it, at least in terms of radiation, well, then so be it. And then I know I've done all I can. Any thoughts from anyone?
I'm sure there's a lot of thoughts here, and it is a strange situation. Just a couple of clarifications I just want to make for my notes before we continue.
Sure.
You mentioned this at the beginning, but I was just pulling your name up just to confirm that your surgery was in 2015, right?
2013.
13, okay.
March of 13.
Okay, so you're 6 years out, and you've had you did do some hormone therapy when you did your salvage radiation, right?
Correct. That was in mid-2016.
For how long?
Well, 6 months of hormone treatment.
6 months. Okay. And other than that, you haven't done any hormone therapy.
No other therapy.
And you, who do you consider to be your main man? The doctor at MSKCC or Dr. O?
Well, that's a good question. Right now, the Sloan Kettering guy is the main man. However, I'm going to go see Dr. O again, and I may well switch to him sometime and at the next visit, which might be, I'll make it up, March or April, something like
Right.
that. I think I like him better. I think he's a bit more. I think he's more knowledgeable, quite frankly. And I'm at the point where, I'm going to need to make soon to make another sort of critical decision. Sloan has been okay because, frankly, I haven't had any treatment, and I've basically, listened to what they say, and his information is consistent with Dr. Rose. But I see some benefits in getting out of the Sloan system as well. I'm still open on it. I mean, there are other possibilities, but that's where I am. I'm going to see both.
And your doc at Memorial Sloan Kettering is still Chen?
Yes.
Well, I just wanted to clarify that for my notes. Since you're facing a decision that Len faced, and you have other issues which Len has clearly had to deal with and is dealing with, let me ask Len for his thoughts.
Yeah, hi, Alan. I had negative scans on Axumin also.
Okay.
At a level just below 1, and I had a technetium 99M bone scan negative.
Right.
Then I had the PSMA PYL scan at the NIH. Is that the one you had?
Yeah.
Yeah. That was positive for me. I had about 3 bone lesions. My PSA at that time was 2.4. So
wow.
If you're
okay.
Yeah, it took me 6 months to get into the NIH trial, and I wasn't on any therapy all that time.
And they found the lesion in your bone, you said?
Yeah.
And had your PSA ever been above 4, or anywhere along the way?
Well, when I was first diagnosed, it was 48.
Oh, okay. All right.
49. Yeah, it was already outside the capsule, Gleason 9. So, I think your question was, when would be a good time to get the PSMA scan again?
Yeah.
I would say now, because at 2.0, and by the time you actually get into a trial, maybe a bit higher, the PYL scan should certainly pick up whatever's going on. And I should say, even after the positive PYL scan, I had another technetium 99 bone scan, and that was negative. So clearly the PYL scan is very sensitive, and it'll be picking up lesions that are missed by Axumin and the technetium bone scan.
Right. So that sounds reasonable. What have you? I had heard when I spoke to the folks at, I think it was UCLA, when I was scouting around for clinical trials the first time, they said to me, you could get up to 2 PSMA scans in total. There was still concern, obviously, about safety of maybe not so much the actual ligand, but maybe the concern around just the scan itself. And that seems what I vaguely recall. Do you have any sort of feeling about safety and whether I would do 2 scans so close together? Is there any concern?
I haven't heard of any concerns. How far back was your last PYL?
It was April of last year, of 2018. So I'm certainly more than a year out.
Yeah.
You know, well more, almost 2 years out.
I shouldn't think that would be a concern. I believe the radio tracer that they use has a fairly short half-life. So, I mean, it should be long since gone from your system.
Yeah, no, certainly that. Okay, so that's fair. All right, so now, when you say do it now, okay, forget the waiting period. I mean, if I could get in tomorrow with a PSA of 2.1, your recommendation would be to do it rather than wait.
If it were me, yes, I would, because while you're waiting, you can't be on any therapy.
Right.
And
but I wouldn't
clearly your PSA is rising. So something's going on, but you don't know where it is. So you want to find out where it is.
Yeah, but I get that. What's on my mind is if I let my PSA go up somewhat higher, let's say to 3, it would increase my chance of finding it.
That's true. Yeah, I mean,
right?
going up to 3 wouldn't be harmful, serious. Right. You know, I think you'd be safe doing that. I'm sure. I imagine Dr. O would agree with that.
Yeah.
I see him also, by the way.
And what was that? I missed that.
I also go to Dr. O at Mount
Sinai. You do? Okay. Okay. Interesting. All right. Well, that's a thought. So I'm going to check with him and all and see. Is there'd be, okay. And let's, again, there's a limit to maybe the number of scans, but you've had 2 of them already or just 1?
I've only had 1 PYL, but I've had 1 Axiom, I've had 2 technetium bone scans, and I also had a 18F sodium fluoride PET scan. That goes way back 5 years.
Yeah. Okay. All right. That's fine. So, all right. So that's some good thoughts. I think that's what I'll have to do. I hate to wait to 4. I mean, if it keeps along the current path, I'll be at 4, late this year. And I don't really necessarily want to wait that long. I'd rather sort of get a read on it sooner. Okay.
And Len also switched from Memorial Sloan Kettering to Dr. O too.
Yeah. Really interesting. And what was your thinking behind that, Len, that you switched?
I initially went to Dr. O for a second opinion, and I found him so, as you did, so knowledgeable, so congenial, someone who gave you as much time as you wanted. He was on top of everything. He's a very smart guy. So for all those reasons, I decided to stay with him.
Right. And may I ask who you had at Sloan?
I had Dr. Daniel Danila.
Yeah, I've heard of him.
Yeah, he's supposed to have been the protege of Michael Morris. And I've no doubt he's a smart guy. And I just got the bum's rush in his office. I typically had to wait over 2 hours just to see him. And then I get like 5 or 10 minutes. And I just got the feeling that he wasn't really interested in having any conversation with me. He was just there to say, okay, this is what you're going to do next. And goodbye.
Right. Okay. All right. That's very helpful. Very helpful because I feel pretty good about Dr. O, and I think I'll go see him and go from there. All right, very good. Any other comment on this? Otherwise, I'll let someone else have their discussion.
Yeah, I was going to ask, does anybody else have any input for Alan?
I don't know. It brought up a couple of points with me. I don't know if
Go
it's
ahead.
specifically Larry. It's Larry. Can you hear me?
Yeah, go ahead, please.
Right. So one thought, which is also related to my situation, is when are situations where the PSA climbs, but it may not be related to prostate cancer?
Well, yes.
Do we know of that?
Yes. I mean, you can, with prostate cancer, you can still have an infection, and that can cause it. You can get inflammation that can cause it. A lot of it depends on what treatment you've already had to the prostate.
And if you don't have a prostate, maybe some of those reasons go away.
Yeah, if you don't have a prostate, then clearly it takes the inflammation issues out of it, Larry. I can't remember.
Alan was saying that the last scan he had showed some what looked to him like hot spots, but were defined as remaining inflammation that seems like it's 5 years, 6 years since his prostatectomy. And maybe there is some kind of inflammation issue that has to be looked at as well if the scans don't show anything. And rather than begin treatment based on scans only and the suspicion that something is going on somewhere.
Yeah, you make a good point. In fact, the radiologist suggested that I have if I want to be extra careful, to have a cystoscopy at my urologist's office. And I'm having that next week just to take a look in the bladder and the urethra and make sure there's nothing visible going on. Not that it rules anything out per se, but it's just an extra measure of investigation.
Yeah, I had that. I had a cystoscopy because I was having some radiation cystitis, and it was a nothing procedure. It's more intimidating in thought than it is in deed, and there was nothing there. The issue that often happens with radiation is it can lead to very long-term inflammation that just doesn't go away. And it's possible that the salvage radiation that you had, Alan, could have possibly irritated some tissue, and the tissue remains irritated.
Yeah,
I've got tissue.
Yeah, I was going to say I wouldn't be surprised because I've had, overactive bladder now for, it's gotten worse over the past few years. And in fact, I'm on now Merbetric, which he's eased my dose up gradually, and it seems to be helping significantly. So all that's consistent, Rick, with your comments.
And just to go a step further, not to complicate, but so when you're discussing getting the scans, on the other hand, I have to agree with Len that why wait and why not go after the scan now? And part of my reasoning is, although right now it's kind of difficult to get a PSMA scan, time is moving forward, and they may become more standard of care after a while, or something else may come along, and then you would be, waiting a year in order to get the scan. Why not get the scan, and then if nothing shows, then you have to wait a year anyway, and then see what's around. That's just a second thought.
Yeah, no, I could do that, I suppose. I think I'll take everyone's advice on that and start investigating, and then maybe applying to clinical trials. It certainly wouldn't hurt because I know even at NIH it took me a couple of months to get in there, and that was before there was a longer waiting list. So yeah, I suppose I can do that. I mean, there's an argument that says if you seed it, if you're going to seed at 3 or 2.8, you're probably going to see something at 2.2. And at the rate things are going, about a 0.04 every week, in a month or two, I'll probably be somewhat higher.
Peter just did a scan, PSMA F18, 18F DCF PYL scan at Stanford. They have a trial there. I think I don't remember if there was any cost or not. I don't think so. But that's, I know it's the other coast, but there is something going on there. Does anybody else know of any places that are trialing scans right now?
I know Sloan has one, I believe, and I just took a brief look the other week, and there are probably others. I didn't do a comprehensive search.
Okay.
Yeah, no, if I had to go to California, it wouldn't be a big deal. A little more logistics effort, but not a stumbling block at all. And I know they have a good program.
Reach out if you decide you want to do that. Reach out to Peter because I think he found them very easy to work with, and he was able to arrange it pretty quickly.
Okay.
So he, as I mentioned, he's going to come on the call, but he's not here right now. Although we do have somebody on the telephone who has joined us on the telephone.
This is Jay Mills. I joined.
Hello, Jay.
Ago.
Welcome.
Hey,
Welcome. Great to hear your voice.
Hi, Jay.
Good to be here. Hey,
okay, so, and Jay, did you want to talk to us about anything tonight?
Perhaps later on, just an update.
Okay, we will do that. All right, well, if there's nothing else, anybody else have anything for Alan, or we'll move on?
Very good. Thanks for everyone's comments on this.
Pleasure. And if you hang up before Peter gets on the call, and you want to talk to him, just let me know, and I'll be sure to connect you to Peter.
All right. Thank you, Rick.
Okay. His email, by the way, is peterk@ancan.org. Peter K.
All right.
Okay.
Very good.
So let's go to Carl. Carl, you're up next.
Wow. Okay. I'm usually later on in the agenda, but I appreciate that. I guess the main purpose of saying that I wanted to say something, I just wanted to express my great appreciation for you, Rick, and for Len and the ANCAN people for all you've done over the year. You've been very helpful. Your advice has been very useful to me, and I'm sure everybody else would agree in that regard. So, keep up the good work. And, we're all here surviving together. And it's great to have the camaraderie. I do participate in other support groups, either via simply telephone or in person or this venue as well. And I find this one by far is the most beneficial for me, and expect to find more helpful advice in the coming year. And I wish everybody a happy new year and a healthy one.
Well, thank you, Carl. That's really nice. I'm curious, who else is running? I know that there's an active surveillance group, and I know that Joel runs a monthly advanced group. Is that the other telephone group, or are there any other telephone groups that that you can share with us?
The telephone group is Joel Nowak, Cancer ABCs. And I think he's twice a month. But he doesn't have anywhere near the number of participants. But again, it's useful, and I get more attention, so to speak, because there aren't as many attendees. But and there's also an in-person group that I've attended. They have a
Yeah.
Once a month on, I think it's the first Tuesday of the month. It's at the, it's in Somerset, New Jersey. And it's run by a psychologist. And more often than not, I find myself as one, the only participant, if not one in addition to another person. And, it's like a whole hour and a half that I spend with him, mostly one-on-one, which is very nice to have. The majority of the participants of the group go at night, and it starts at 6:30 in the evening. For me, during the winter months, it's hard because of driving in the dark, so I haven't gone at night. So there's about 15 people who go at night, but only 1 or 2 during the day. So once the secret's out, maybe I shouldn't say anything. They'll all start during the day.
Right. You say it's difficult to drive at night. Is that a side effect from one of the drugs that you're taking?
Not that I've been told or aware of. I think it's just night vision as getting older, and also trying to sparse the differences between the disease and age. Like, for example, I was recently diagnosed with spinal stenosis, and I asked the doctors, I said, does that have anything to do with my prostate cancer? They said, no, that's your age. And also some arthritis. I recently had an x-ray of my left thumb, and they said, oh, that's arthritis. And, they said it goes with the territory. I mean, I just turned 65, so I guess not to be unexpected.
Well, I mean, the worst thing for me is that when you do have an injury or an issue, it just takes so much longer to heal than it used to even 20 years ago. That's the biggest issue. But I ask about the eyes because, and Len may be able to help me here, there is a prostate cancer drug that does affect night vision. I think it's bicalutamide, if I'm not mistaken.
I can't think of any, Rick. I don't.
Yeah, I
recall.
I think it's bicalutamide because I remember people being put on it and being advised at the time that it can affect your night vision. Why? I have no idea, but I don't know. Maybe somebody will research it whilst we're talking. But I know there's definitely one of the drugs that affects that does affect night vision.
I have to say that my eyesight actually improved somewhat after I had the immunotherapy, the Provenge treatment. Within several weeks after I had the treatment, which was back in March, April this year, then I went to my ophthalmologist, and she said, I don't understand it. Your eyesight has improved. And I explained to her what the difference was, that I had that recent procedure. So.
Interesting. I don't know. I'm not sure. I'm not sure what that one's about. But anyway, well, thank you so much for your kind words. Is there anything going on that we should know about with your situation? Are you still, as of close to the end of the year, are you still undetectable?
Well, my oncologist appointments have gone on to a more extended schedule. It was every 6 weeks, and now it's 3 months. So in about, I think it's January 18th is my next appointment with Dr. Soraya. So things are kind of somewhat on hold. And but in the meantime, I did reach out to another doctor who is an MD and a physiatrist. So I did have a 2-hour meeting with her about 2 weeks ago. I had very extensive tests, nutritionally oriented, actually, a blood work with Quest that showed all different parameters relating to nutritional markers. And also I had a stool test, which was kind of interesting, where it came back that I was positive for H. pylori. And I had there's a bacteria in the stomach. I had that a good number of years ago. I had gone to a gastroenterologist, and he put me on a very heavy dose of antibiotics, which is I had to be on for about 2 weeks, and I think the protocol still might be the same in order to knock it out. So I mean, I've been having some stomach issues, and I've basically been attributing it to one of the side effects of the medications I'm on, which it clearly says that is one of those side effects. But the fact that it's now showing the H. pylori and a couple of other bacteria, when I followed up, my next appointment with the physiatrist is January 8th. So in the meantime, I figured, okay, I really want to address the H. pylori sooner than later. And as anybody's had experience with these gastroenterologists, you don't get an appointment right away. So I did actually just get an appointment. It's going to be in February, so it's going to be after I meet with her. And I then also went to my primary care doctor to talk about the results. And my regular doctor's on vacation. I saw her at PA, and the PA said, well, you know, I know these guys very well who are infectious disease doctors. And I said, why would I need to go to an infectious disease doctor? And she said, I think they can help you with this. And I did call up for an appointment. I have an appointment with them scheduled. I haven't had it yet. So they actually also said, well, you should also go to a gastroenterologist. But, you know, I'm just going to keep pushing and then going after things as much as I can.
How are you doing with your medical marijuana?
Well, you know, I was the very first person from my oncologist. He had just recently got his license to issue these permits. And he said, you're going to be my first one. I said, okay, fine. I went to the dispensary. I got these, they call them edibles, but they're like mints. And they had a nighttime version and a daytime version. So I was taking the nighttime version for about a week, and it didn't seem to do much of anything. And when I went back to the dispensary, they said, oh, now we have a daytime version. I said, okay. I took the nighttime version, which is 5 milligrams of THC, and I was taking 2 of those. And then I took one the next day for the daytime. I ended up in such I don't know how to describe it, a funk. I was dizzy, I was disoriented, and I couldn't believe. I was very concerned about the effect. So I sent an email to my oncologist, and then he said he was going to check with the pharmacy, and then the pharmacy came back, you shouldn't be taking it. Well, how come he already issued me the permit to do the medical marijuana? Now, the physiatrist that I went to, I told her about my situation, and she said she knows a well-known doctor at UCSF. I think it's Dr. Arnold, but she said that she worked under him for some time, and he's done a lot of studies and research about using medical marijuana, and it talks about how positive it is for prostate cancer patients, and that I should reach out to him. So I haven't actually followed up on that yet.
So I just want to follow up on one issue, and then we'll move along. But what the pharmacist said you should not be taking medical marijuana. Now, was this a specialty pharmacist or a regular pharmacist, and what was their reasoning? What drug are you taking that it interacts with?
It's the pharmacist as part of the Cancer Institute, so their resident guru, whatever, pharmacist there. And based upon the olaparib and ADT therapy, it was their opinion that it wasn't cohesive or wasn't working in concert well enough.
I mean, I've not heard that before on these drugs. I mean, certainly people on ADT, I've known many people on ADT use medical marijuana. I don't know if there's an interaction with the PARP inhibitors. I've never heard of one before. but I really would be interested to know their rationale and if it's just a prejudice or if there is a
The folks that are
clinical
running for
reason.
president, people.
You know, and
Anybody-
I'm sorry, I just did find the email from my oncologist, and he wrote to me and said, looks like the biggest concerns with interactions are what you already are worried about, significant potential interaction with Zoloft. So that's sertraline that I take, generic Zoloft, and tramadol can cause decreased mental acuity, concentration, confusion, etc. Would advise against continuing to use at this time, or be very careful and have your wife keep a close eye on your mental function.
Okay, so it was so what they're concerned about is the tramadol and the Zoloft.
Right, right.
Yeah, that I can see. That I can certainly see. Len, you have a comment on that?
What I'd like to know, Carl, is 5 milligrams of THC is a very low dose. Was there anything else in those edibles? Like, was there any CBD? Was there indica, an indica strain of marijuana? Do you know any of that?
No, there was no mention of indica and the CBD. I'm not sure.
Okay. Anybody else have any questions to Carl on anything we've discussed, including the
I
marijuana?
I could add a little bit. 5 milligrams of THC will get me high. If you took more than that during the day, like 6 or 7, I get really loaded. You know, some people are more sensitive than others. You might just have had too much that day. That's all. It's simple as that. Find out how many milligrams you had during the day for that daytime thing.
Yeah, the daytime one is also 5 milligrams. So I had 10 milligrams the night before, and then during the day, less than 12 hours later, I had the daytime version. So,
oh, you could even tolerate more than me. If I had 10, I'd be really loaded and dizzy and, you know, spaced out.
wow.
Yeah.
Carl,
Yeah, I mean,
Rick, can I just ask Carl about the H. pylori? Did you ever have stomach ulcers or heartburn or gastroesophageal reflux, anything like that?
Interesting that you say that. Yes, but no, it was a long time ago. I was on a generic over-the-counter acid reduction type medication. That was a good number of years ago.
Okay. But now they found the H. pylori, which can often cause those symptoms, but you don't have the symptoms now. Is that right?
No, other than some stomach tightness and some pain, which again I attributed to the medication.
Yeah.
And I wouldn't have known without going to this particular doctor and having this. It's called diagnostic laboratories. They call it a DNA stool analysis. Apparently very high tech, and which a regular physician has not done for me. Or they probably don't even know about.
You didn't have any blood in your stool?
No.
Okay.
Okay. Well, thank you for all that update, Mr. Foreman. And by and large, it sounds like you're doing okay and managing fine. And we're all, you know, I think the one thing that I can say is that when I think back to a year ago, September, when we met you, thank goodness you are so much more relaxed and dealing with this in a really commendable way. And you know, I hope you can stay on track with that, because it isn't easy. We know it isn't easy. So, you know, kudos to you.
Thank you. By the way, where is Shakopee, Minnesota? Because I sent in a check, a contribution to your foundation, and it sent it in the mail.
Oh, well, thank you. Thank you so much. Shakopee is a suburb of Minneapolis. And when we lost Rob, who was our treasurer, and way more, but we didn't even know half of what Rob was doing until we lost him. We were fortunate enough to, through LinkedIn, to find a wonderful lady who is now our secretary treasurer, Tanya Doring, and she lives in Shakopee, which is about 5 miles from where Rob used to live, ironically. And so that's why the checks go to Shakopee, and we're also a Minnesota 501c3. But thank you so much. She's on vacation for 5 or 7 days, but I'm sure she'll process it when she gets back, and you'll get an acknowledgement from her. And thank you so much. And to everybody else who's on this call who has made a donation at this time of year, they've all been received. I try and personally acknowledge everybody when I get the message, or either I do it or on occasion Len takes care of it too. But thank you, everybody. Okay, let's move on to Les. Les.
Okay.
How are you, and what's on your mind?
Okay, a couple things. Well, first, I did get acknowledgement almost immediately on a donation, so that someone's answering it anyway. The two things that I've got, one personally, is that my PSA, I just had a blood test. The PSA is still 0.1, and the testosterone is now up to 370. The other thing I wanted to comment on, early November, you had mentioned this US2 webcast on prostate cancer pathways, and I had said that I had signed up for it but couldn't attend, and I'd hoped they'd have it on recording. I noticed they do have it. I don't know if you've seen it yet, but they do have that available. So if anyone else missed it, that it is currently available online. That's all I got.
Okay, well, we'll unpack a couple of those, but the first thing is that, yes, thank you very much for mentioning the US2. I actually have it in my notes to include it in the next email, the next reminder that we send out. We'll put the link in there for everybody. Somebody, either Jake or Len, maybe can put the link in the chat window right now. Jake was kind enough to send it out to a few of us. And I would recommend listening to a couple of people. I thought Maha Hussein was pretty impressive. There was a radiologist who was very impressive. I'm trying to think who else. Alicia Morgans was involved, but she was really more of a sort of the moderator. I missed her comments at the beginning in the afternoon, so I want to listen to that, but she didn't speak for very long. She basically, I think, introduced Maha Hussein, and then she moderated a panel. But yes, if you got a few minutes, it's worth delving into. There's I think some speakers that address lesser topics as well. I mean, topics that might not be so interesting to advanced folks, but it's definitely worthwhile. Len, didn't you listen to it already or look at it? You're muted, Len.
You're speaking of the Chicago conference, not PCRI.
Yes. No, the Chicago conference.
Yeah, I did get to listen to some of it. The video quality is excellent, and it was very interesting. There's a lot more I'd like to listen to. As a matter of fact, we should probably tell Jay Mills to give a listen, because Maha Hussein does talk about intermittent ADT versus continuous. And just a spoiler, Jay, she believes that continuous ADT has a survival advantage over intermittent. And you can cherry pick your own clinical trials and come up with a different opinion. So it's still a controversial issue. But in any case, yeah, I do recommend people at least take a look at the very finely granular table of contents. Minute by minute, they let you know where a discussion begins or ends, so you can jump right to it. Jake posted the URL in the chat room. For anybody on the phone, like I know Jay is on the phone, I can email that to you, Jay.
Okay.
Thanks, Len. Yeah, it is worthwhile. The speakers were all excellent. I mean, the only speaker that I found at all lacking was the patient advocate that they had speak. And I mean, for me, you could skip right over that one, but I thought all the doctors that spoke that I heard were very good. I think I missed the surgeon, and I switched on when the radiation guy was speaking. So let me just address your PSA and your testosterone, Les. First of all, delighted that your PSA is still less than 0.1, and it's great to hear that your testosterone has finally come back. I mean, how long has that taken, Les?
Well, I've been theoretically off for, well, a couple days short of 6 months. And the PSA, by the way, was 0.1. It wasn't less anymore, but it was 0.1.
0.1.
I don't know if that makes any difference or not.
What was it like? What was it? 0. I see in 1019 it shows a 0.1. So if it shows a 0.1 in 1019, then, and it's still 0.1, I would be comfortable with that.
Yes, I think the last 3 times it was 0.1. Prior to that, for some time, it was so-called less than 0.1. Again, the significance, I don't know.
And are you feeling significantly better with this higher level of testosterone?
I don't know about significant, but I do notice a difference. It is definitely detectable. One thing that I would like to ask, I'm not sure if it's got any connection or not, but I do notice my mean time between potty stops is greater. I don't know if that's any connection or not, but I don't have to get up quite as many times during the night and not quite as frequently during the day. I don't know if that's any connection to the testosterone or not.
Then anybody else noticed any correlation between your testosterone levels and your frequency? I don't know. I mean, again, I'd urge you to consider using a drug to help you so you get better sleep. Myrbetriq is what Alan mentioned earlier on, and that's an excellent drug. But it is a discussion that's worthwhile with Quan or somebody, because I know you've been in the habit of getting up very frequently, and that cannot help because you have very broken sleep pattern.
Yes.
Anybody else want to say anything to Les or comment? And Les, again, thank you so much for providing the PCRI stream. And
I would add just,
by the way,
I'm sorry.
Just let me finish, Alan. I'll come to you. Thank you so much for providing the PCRI stream. And we do have CDs available if somebody prefers the CD rather than the stream. But it's just less convenient for everybody because they've got to be mailed out and they've got to be mailed back. Alan, go ahead.
Yeah, I was going to make a comment on the urinary frequency that the other gentleman just asked about. What I have found is that my nighttime frequency of urination was cut down substantially by eliminating fruit in the evening. So I would usually have something, not a citrus fruit, but even things like a melon or grapes and things like that. For whatever the reason, it would irritate my bladder, and I'd have to get up sometimes 3 times or even more during the night. And eliminating that, or at least cutting it to something very bland like a pear, made all the difference. The other comment related would be, I've taken over the years, I would tell you more than 20 years, I've taken a half a Benadryl, sometimes a whole Benadryl, to help me sleep. I'd wake up too early in the morning and I could never get back to sleep. And as you can imagine, if I'm waking up to urinate, it gets harder and harder to get back to sleep. And so that also could be a help if your issue relates to the ability to fall back asleep. You're just a bit drowsy, which will make getting back to sleep a bit easier. Now, in my case, even after all these years, I have found that Benadryl has more or less stopped working or not working as well, and I've switched to like a Unisom type product, which does not have the same active ingredient, and I have to take just a little of it, otherwise it knocks me out the whole next day. So those are just some of the tricks that I've learned. Obviously, I don't have caffeine because that aggravates it. And I think if you maybe keep a log or keep an eye on it, you might be able to discern for you what are the main culprits, given that I'm telling you fruit seems to be a big one. Okay, hope that helps.
As far as my involvement with the fruit, I normally have fruit in the morning. I normally don't have much fruit in the evening at all. Maybe a couple slices of apple once in a while, but otherwise, my fruit is normally consumed in the morning.
Right. I would suggest, even with that, try a day or two in a row without any fruit. See if it makes a difference at night, because that lingering sort of urgency and all, you might find an improvement, but there's no way to know without trying.
Has the Mebetric helped you in terms of the urgency issues?
Yes, I have. And previously I tried my Mebetric a few years ago, and it gave me stomach pains for some reason. But as it turned out, my doctor at the time just gave me a sample of 50 milligrams, and I was on it for, I don't know, a couple of weeks, maybe a bit longer, and it started to aggravate me, so I didn't continue. My current doctor gave me 25 milligrams. I took it for about 6 weeks. I saw some improvement. He said, it's not going to be perfect, but it will help you. And so now I've been on the 50s about 2 weeks. So far, I haven't had any trouble, and I have seen a big improvement. I'm able to eat a little bit of fruit that would bother me, and now it doesn't. So it really controls the spasms, and he said it will still keep improving for me, maybe over yet another month. So a total of 3 months. So it does help. Now I will say this: it helps the frequency a bit, but in my case, it helps the bladder contractions, the bladder spasms, significantly. There was a noticeably less intense spasm, which is my main complaint. The frequency I can live with, and I'm hopeful that'll subside over time.
What drug did you say there was? I didn't quite hear it. What drug
Yeah,
were you?
it's an odd name. It's Myrbetriq. It's MYRBETRIQ. If you type in MYRB, you'll get it. It's expensive, I will tell you that. At least the initial price. It subsides after, I guess, you meet your Medicare deductible if you have that.
Yeah, it is expensive, and there are other drugs that are similar, but I don't think there's anything that's as good.
Yeah, Myrbetriq works. It works with a totally different mechanism than any of the other drugs. All the typical ones that you know, Vesicare, oxybutynin, ditropan, Enablex, all those are all these anticholinergic drugs, and they all work in a similar manner. I think Vesicare is supposed to be the best of the lot, only because the side effects are less so. The others give you dry mouth and some other minor annoyances. But Myrbetriq is a bit better than that. In fact, the medical insert that comes with the drug also suggests a combination. They've tested the Vesicare in combination with Myrbetriq. And when I asked my urologist about it, he said, let's start with one drug first and see how you do, and we'll worry about adding the second drug if needed. So yeah, you can read about it. It is a good drug, which is probably why they charge you so much for it.
Yeah. Okay, I put it in the, for those of you online, I put it in the chat window. We have somebody else that arrived on the telephone. I'm wondering if it's Peter or somebody else.
Well, wonder no more.
Okay, Peter, how are you?
Okay.
Good. All right, well, Alan just hung up, but he may be in touch with you to talk about your trial at UCSF. So, excuse me, at Stanford. So we mentioned that to him, and we may well connect you. So let's keep moving along. Joe Blanchette, what's on your mind?
Okay, you asked me a couple of questions to ask Dr. Antonarakis, and I did, and he was very helpful. He was very, he answered them actually in 10 seconds or less because he knew the answers. As far as AR-V7, if it's positive, you will not do well with enzalutamide and abiraterone and apalutamide and darolutamide. They're all the same reaction.
Okay.
Now, if you take a round of chemo, that can reverse your AR-V7 from positive to negative. That's the second question you asked me.
Okay, that is very, especially the second piece of information. I mean, they're both very helpful because we're just still not at all sure about darolutamide. So, in Antonarakis' opinion, if you're AR-V7 positive, you will not get a result from darolutamide as well as the other three drugs.
That is correct.
Okay, excellent. And but chemo can reverse. You can start off as AR-V7 positive, and chemotherapy may possibly reverse the.
Correct, and it's the only drug that will reverse it.
Okay. Okay. Did he specify what type of chemo? A taxane-based chemo or?
He did not specify.
Okay. Well, most likely I would think a taxane-based chemo because that's usually where you start with chemo for prostate cancer. Thank you so much for asking those questions. That's really helpful to some people that are on this call right now, I know. What about your own issues, Joel? What's going on?
Okay, at the time that I went to see him, NIH had not come up yet with my bone biopsy results. But Anton Arakis said, it doesn't matter what the results are, I'm going to treat you for prostate cancer anyway, because as long as I have 2 scans that says you have prostate cancer, you will be treated for prostate cancer. So by the way, the bone scans results did come out 3 days ago, and all 3 bone samples they took out of me were all prostate cancer. They were not Paget's disease like some of the doctors NIH suspected. Anton Arakis said, since you only have 1 bone lesion, I recommend that you go on radiation therapy. There's no point in treating this system because you have nothing wrong with your system as we know it yet. Just let's do the radiation. He says, I recommend SBRT. All you need is 3 days of radiation and you'll be done with it. And then we'll monitor your PSA. So that's what his opinion was. And so he sent me to a doctor at NIH, Dr. Tran, T-R-A-N. And actually, I never saw Dr. Tran because Dr. Tran was pursuing me via phone. So we talked about 20 minutes one Sunday night. And then the next morning, I was supposed to go see him, but the appointment got postponed and canceled 3 times. So I ended up showing up at the wrong location. So I never did see him. But then he called me when I was in the car driving back home. And we talked some more. And the reason he was calling me and recruiting me, he was trying to recruit me for another trial, which involves both radiation, SBRT radiation, and Xofigo. Xofigo, as everybody knows, has been approved by the FDA several years ago for castrate-resistant prostate cancer, but has not been approved yet for hormone-sensitive prostate cancer. And that's what the clinical trial is about. And so Anton Arakis had said, well, 30 days after the radiation, we'll check your PSA and we'll see what it's doing. I don't expect it to be 0, but at least it should be going down. So if I took the clinical trial, after 2 weeks, after the radiation, 2 weeks later, they'd give me the Xofigo for 6 consecutive treatments every month for six months. So then I would never find out if the PSA did go down. I wouldn't know if it was the radiation doing it or the Xofigo doing it. So I elected not to go that route yet. I mean, I may be interested in the Xofigo if I fail radiation several times in the future, because Xofigo goes after prostate cancer that the scans can't see yet. Very small cancers in the body. So tomorrow I'm seeing another radiation oncologist, not a John Hopkins guy, but a Virginia guy, Dr. Eblin, and for a second opinion, basically, just want to know what he says. I don't know if SBRT is the best radiation for me. Radiation oncologists should know that, of course, which one is best. Because Eblin has briefed us in my prostate cancer support group in the past, and basically he does all the radiation modes, and he supposedly gives you the best radiation for where the spot is in the body where the prostate cancer is. So anyway, I was wondering if anybody on the call had experience with that, with radiation, and the fact that it's on the iliac crest bone, and Anton Arakis said it's close to the skin. It's an easy spot to get to, so that's why I recommend only radiation at this point. I mean, Lupron can be given later on if radiation can't can't do it. But he said that most likely the cancer will not reoccur where we radiate. It usually never does. It might come back to another bone someplace else, but it won't if we radiate that spot. And he says we'll radiate it with a couple millimeter margin so that we can get it all. And he says it's possible to get it all, but he says some guys, that happens to a few guys, but not everybody. So that's where I am basically.
So, so this fellow Tran, did you say he was at the NIH?
Yeah, he's at the NIH. He's a doctor at the no, I'm sorry. If I said NIH, I meant John Hopkins. I apologize.
He was at Hopkins.
Yeah.
Well, what I would say to you, I think if it were me, I would have made the same decision as you. I'm very skeptical about Xofigo for many reasons. But one of them is that although this isn't applicable to you right now, it eliminates you from the lutetium-177 PSMA trials, which, thank goodness, you don't need at this point in time. And by the time, we hope you'll never need it, but if you do, it should have been approved by the FDA at that point, so you wouldn't be wrestling with exclusions, trial exclusions for prior use of Xofigo. But I just don't think Xofigo is a great drug. It because it's attracted to all bone, it can have side effects that PSMA targeted radionuclides just don't have. So I think I would have made the same decision as you with respect to the Xofigo, although others might have chosen differently. I'm very interested in Dr. Antonarakis' approach, which I think is a very compassionate approach, which is to use the spot radiation and not to put you on hormone therapy just yet. My guess is that most GU med oncs that we know would have put you on the hormone therapy. So let's hope that you get a really good result. We must have some guys on this call who have done spot radiation. So let me throw it open. Anybody want to discuss with the treatment choice with Joel? Anybody done spot radiation?
This is
Yeah,
Joe Mills.
I did one on my pelvic bone after it was discovered it metastasized, and that seemed to hold everything back for a while.
And how many sessions and what type? Was it SBRT, Jim?
Yeah, 12 sessions.
12, did you say?
Yeah.
12 with SBRT. Joel, questions for Jim?
I guess that was that SBRT was the recommended mode. I guess I'll find out more tomorrow if this other radiation oncologist recommends the same thing. The radiation oncologist at Hopkins, just wanted to make one more comment about him. He refused to treat me with just radiation because he was recruiting for his trial, and it's a 64-man trial, and he's having a hard time. He's only had recruited 6 people so far. And so he refused to give me radiation, but he says there's plenty of other radiation oncologists that can do it. I think for radiation oncologists, it's easy. What I have is easy for them to do.
Wow, that's really interesting.
What was that trial for?
Xofigo and SBRT for castrate sensitive.
Okay.
For castrate sensitive prostate cancer.
Okay.
Wow. I mean, I'm sure I'm sure there must have been other docs there, but you can, like you say, you can find somebody probably closer and just as good for that. Jay, you had a question?
No, I was just a comment that I had HDR to my prostate, then 5 weeks of IMRT to the prostate area. But I had on PSMA, I had a suspicious area on a rib that may or may not be cancer, and they recommended I treat it with SBRT. It was on the front, and of course it's shallow. It doesn't involve any major tissue other than just skin on top. So they recommended irradiating it, and then no side effects. And it's hopefully, like if it was cancer, hopefully, like you said, it would not come back there. That would take care of that, hopefully.
Let us come back to you on that, because that's sort of new news, and I do want to finish up with. I mean, we will get. We're going to go to Jim, and then we're going to get to you, and then Peter. But
right, I was bringing it up just as a comment. He was questioning whether he should use SBRT, and it was, to my understanding, SBRT is the most exacting method, other than what's the other one that they do out in Southern California?
GPRT.
Proton.
Yeah. Those two. Yeah, those two are the best currently. That's all I have.
Okay. No, we want to come back to you and talk to you about a couple of things, Jay. So, Joel, any other questions before we move on?
Yeah, well, the only other comment I have is John Hopkins, Anton Arakis said that he had two other radiation oncologists at John Hopkins. So John Hopkins is not totally out of the competition for the radiation oncologist yet. But I was going to get a second opinion from this other guy that I'm seeing tomorrow anyway. So between what Anton Arakis tells me and between this other guy, I'll have a pretty good idea as to what to do, I think. Because the fact that one guy didn't want to do me because he was only recruiting for a clinical trial does not negate the fact that Hopkins could radiate me if they wanted to, unless all their radiation oncologists are all doing clinical trials for some reason. But one interesting thing that I got from Anton Arakis on 1 October, interesting enough that I asked him a question when I saw him on 17 December. He was sort of alluded to the fact that he wasn't in favor of ADT, and I didn't know if that was a John Hopkins thing or a Anton Arakis thing. And I asked him directly. He's really a straight shooter. I really like him. Very professional, very straight shooter. And I says, you mentioned in October that you're not favoring ADT for me, and he says. I says, is that a John Hopkins thing? He says, no, that's a me thing. And so for some reason, he thinks that he wants to stay away from ADT if possible. And so he says, you're the perfect candidate not to give ADT to, as far as he was concerned. So I just want to mention that because that was an issue that I had.
Yeah, no, I mean, I think it may be interesting to, hold on, Peter, I'll come back to you, but I mean, that is an interesting approach. So when would he start giving ADT, or what does he do in place of ADT?
Well, I guess the radiation is the first thing. What he would do next, if it popped up in a different bone, I think he would radiate that bone too, keep on radiating me until it was multiple spots, I guess, and then we would switch to something else. Whether that was ADT or not, I don't know, or if he has another drug in mind, I haven't queried him on that.
Peter, did you want to say something?
I just have a question. Do you have any pain with this bone met, or is it just something that was discovered in a scan?
I'm not quite sure on that. I don't think I have any pain. I have some residual pain after they took 3 bone samples out of my iliac bone, but other than that, I don't think I have any bone pain. I didn't even know where my iliac bone was until they carved into it. But no, so far I have some pain. I've had 2 hip replacements. I've had some pain in my right hip After the first year, after the right hip was replaced, had no pain at all, and the pain came back about 6 months ago. And I talked to the doctors at NIH about it, and she said, well, it could be a referred from the iliac bone that's on the left side. But of course, she wasn't sure about that, and nor am I. So whether I have bone pain, go ahead.
So this just popped up in a scan then? That's where they found it?
A matter of fact, all 4 scans found it. 3 PET scans found the prostate cancer in the iliac bone, and the CT scan, which I had taken 2 years earlier that didn't find it. The CT scan, even the CT scan found it this time. So I had 4 scans corroborating each other about one spot in the bone and iliac.
Interesting. And no lymph nodes. You have no lymph nodes spread.
No soft tissue involvement at all. Yeah.
Good. Well, I think you're doing the right thing. I think it's a smart move.
All right. Thank you.
Len, did you have any pain in your iliac bone after you did your bone biopsy?
No, not following the biopsy.
Okay. Okay. All right. Anybody else like to say anything to Joel before we move on? Okay. Well, since Peter is now on the line, Jim, why don't we come to you?
Oh, okay. I've had a couple of tough weeks. I started Zytiga at the end of May, but I couldn't do it because I was getting bone pain and feeling awful. So I stopped that, and they put me on, is it Erlita or Erliata? How do you say it?
Erlita.
Oh, okay. And started that the beginning of November, and I was doing pretty good with that. My PSA had gone down with the Zytiga, but then after I stopped it, it started going back up again a lot, from like 4 to 6 to 11. And so I started Erlita, and it went down in a month. It went down to 10.9. But about 2 weeks ago, I started getting terrible stomach aches at night and throwing up and feeling, ever since starting Erlita too. I mean, Lupron's bad enough, and this doubled it up on the fatigue part. So I had a battery of tests. They didn't know if it was Erlita or what was going on, why I was throwing up. And everything looked pretty good except for my blood count. My kidneys looked really bad. Creatines went up, and I forget the number of the EGFRs part of it, where it's supposed to be high, that went in half. And they said, I really have to look at my kidneys now. I did go, when this started happening, a week ago, to Dr. Okazaki, the oncologist, and he basically shrugged his shoulder and said, well, we don't know if it's the Erlita or not. If you keep throwing up at night, go to your doctor, go to your PCP. So right now I stopped the Erlita, and I'm starting to feel better. It took about 5 days after I stopped it to start feeling better, not throwing up all the time, having stomach aches. So I don't know what to do, without it. I don't know. My testosterone's like under 12. It's like zeroed out. And I feel like just not doing anything. Just I've had the Lupron shot and just see what happens. I don't know. I'm so frustrated, with it all. So that's my story. I'm going to get another blood test to see if my kidneys get back to normal. They said it could have gone crazy when I was having a bad week of waking up and doing dry heaves. So, but they don't know for sure.
So the main side effect that's really bothering you, that you think may be related to the Erlita, is nausea and vomiting, and is your do you have diarrhea as well? Is your stomach upset or not?
No. If anything, I've had more constipation, and my stomach has been upset. Not really. I hadn't had diarrhea or really constipation, but yeah, my stomach would get upset, and then it would go away, and then it would get set and go away. And in the middle of the night, I'd wake up even though I was sleeping upright a little bit. and have a really terrible stomach ache and do dry heaves, you know, for a bit, and then try to go back to sleep, and that would be hard. And I looked it up, and Erlita does, it said that 30% of the people who had to stop it, stopped it because of nausea. And that is one of the side effects way down on the bottom, though. They don't list it pretty high up at all.
Right. What percentage did you say, Jim?
I think it, well, it said 30% of the people who had to stop it, stopped it because of nausea.
You say your PSA came down to 10.9. What was it? What was the previous number, and when was that?
11.2, and that was November 9th. And then December 12th, it went down while I was on to Erlita. And then about a week after that, right about December 15th, 16th is when all of a sudden I woke up in the middle of the night and all this started, throwing up and nausea and feeling terrible. And that just came on like all of a sudden. So I don't know if it's Erlita or not, but they did a whole test on, you know, H. pylori. They did an ultrasound on my abdomen. They did an ultrasound to see if I had a hernia. They did a P test and a couple other tests, and everything looks okay except for the kidneys.
What was your PSA in November before you started it, or when you started it?
Well, the Zytiga originally took it down from 4.7 to 3.9. When I stopped it, it went to 6 in September, and then November went to 11. And then December, after I started Erlita again, it went down to 10.9. After the Zytiga, it doubled basically.
Right. So it went to 11 plus in November, and basically it didn't go up anymore, and it came down a tad in December. So it was probably doing something.
Yeah,
Jim,
well, that's the assumption. Yeah.
Did you get any traction today by calling UCSF and trying to reach Dr. Borno?
You know, I was going to, and I tried to go surfing instead. It was the first day I felt good, so I went in the water. I didn't call.
Okay,
but I intend to call.
Promise me you will try to call them tomorrow. You're going to probably less luck getting anybody tomorrow than you would today. But promise me in the morning you'll wake up and try to get somebody at UCSF, so at least
okay,
they're
I'll do
tracking
that.
you, and at least they know what's going on.
I will. I'll give Borno a call.
The other thing I can do, if you would like, is I can reach out to Janssen and see what thoughts they might have on the nausea and also on the kidney issues. I don't know how much they'll tell me because they usually play it close to the chest, but my relationship with Janssen is good enough that, you know, I can tell them that it looks like the Erlita might be working for you, but you've got stomach issues, nausea, possibly kidney issues, and see what they say. You know, they may just say, well, tell him to talk to his doc, but I will tell him that I'll tell him you're talking to your oncologist, provided you call Dr. Bono tomorrow.
Sure. Okay. Man, this is on tape.
Yeah.
we got you. We got you.
Burn that tape.
Yeah, but I do know. I mean, I know the prostate cancer folks at Janssen pretty well.
Well, it also doubled the exhaustion factor. Man, I did fairly okay through chemo and the Lupron right after, during and after it. I was still functional, but when I started the Erlita, it really took the fatigue. I mean, I couldn't do much at all.
Yeah.
I mean, walk 100 yards, I'd be tired.
So you didn't try and exercise through it because the idea is, as tough as it is, if you can exercise through it, it's going to reduce that fatigue factor.
Yeah, no, I did try, and I worked in the yard a lot, and I did try to exercise, but it came on pretty fast. I thought I was doing really great for a week or two, and then it started really hitting me.
Yeah, I mean, I know people like to think that working in the yard is good exercise. I've been hearing that for 10 years, but it's that consistent exercise where you get your heart elevated, you keep it elevated, that makes the difference. And we've just heard it from so many people that, I think it does make a difference. So if you were to go back on the apalutamide, I would say that would be an important element. The other thing is that maybe to try a different drug, either enzalutamide or darolutamide, and see if you respond to them the same way. And that's the discussion to have with your doc at UCSF tomorrow, because
Is
they're going to have the
darolutamide?
best.
Yeah, can I be approved for darolutamide? Because one might be going up and down and up, so I don't know if I'd be approved for that.
Well, I think that there are ways these doctors can get them for you, and they can justify a different drug to apalutamide because it's not working for you on apalutamide.
Yeah.
And I think if they got you, Len, help me out here, but wasn't the darolutamide approved for the same space as the apalutamide?
Yes.
I think it was.
Jim, are you metastatic or non-metastatic?
I'm metastatic. It's in my bones. Yeah.
Technically, darolutamide is for non-metastatic only, whereas Erleada is for both at this point, metastatic and non-metastatic.
Yeah, that's what I thought.
But yeah, one thing I didn't quite understand, it sounded to me from what I heard from you is that Zytiga brought your PSA down to something like, I don't know, 3 or 4.
Yeah.
Yeah. So why did you stop that?
I was feeling terrible it was hurting my bones actually, even with the what do you call it? Even with the pill the day after and whatnot, it was really bothering me. It was like statin effects. I could hardly walk. I was getting pain in my back and around the side of my leg. And it just felt it just hurt everywhere.
Okay. Yeah.
Well, sometimes if you fail a drug like the Erleada, the apalutamide, the docs can get you these other drugs that may not have been approved in the space if they recommend them for various reasons. So this is why I think Peter's spot on that you've got to talk to your lady at UCSF.
Yeah, yeah, and I do appreciate the tip on getting your heart rate up, because when I go to the gym, that does help, and when I swim, that does help. And my wife said the same thing: yard work is an exercise. And she's right, I guess. Even though it gets really tired.
I know. I mean, yes, it is exercise, but swimming is fine. I mean, if you don't want to go to the gym, just go in and swim whatever you usually do in the ocean. I mean, that's perfectly good too.
Yeah, I got to go to the gym more and get the heart rate up. I think that might help, whatever I do in the future, for sure. They also said that's really good for your kidneys. The nurse said get some exercise on top of drinking a ton of water. So we'll see what happens next week when I get a blood draw.
Okay.
I missed something.
Go ahead, Larry.
Did you say that you had tried Xtandi before?
No.
Wouldn't that be an option to consider? It seems like when you say your PSA went down from 11.12 to 10.9, it's like a point, 03, a 0.3 change versus the kind of doubling time that you experienced when you stopped Zytiga, talking about 3, 4, 6, 12, 3, 4, 6, 11, that maybe those tests are not that significant. That how often do you getting your PSA checked? Every month?
Every 6 weeks.
Yeah. Okay. Good. And I don't know if darolutamide is not appropriate at the current time, and there's no convenient trial for darolutamide. Why don't you try extending it? Maybe as effective as the Zytiga was, and maybe that'll have a major effect. I'd like to see. I'd hope that you get something that would say 10.9 and now it's 8.2 and now it's 6.1, really showing not to hang around with 0.03, 0.3, 0.1, waiting for some other metastasis to take place. I don't want to say it that way, but I think that's where the risk lies.
Yeah, for sure.
Well, the reason why we're pushing the darolutamide, if there was a way that the doc could get it for you, is because it's going to have a significantly lower fatigue factor.
Oh, really?
And
that's good.
Yeah, because it doesn't cross the brain barrier, so it doesn't affect the androgen receptors in your brain. And this is the point that I hand over to Mr. Sierra.
Yeah, that's true. At least in my experience and in clinical trials, darolutamide seemed to produce far less fatigue. And by the way, Jim, I forgot to ask you, you said you're metastatic, but was that with a PSMA scan or a technetium bone scan?
PSMA trial at UCFS.
Okay, have you had a technetium bone scan?
Yeah, I did.
Was it positive or negative for Mets?
Well, they said they couldn't tell. I'm not sure which bone scan I had. My back was really bothering me, so they did a bone scan. I'm not sure what kind that is. And they saw some arthritis in my sacroiliac that was right next to a tumor, but they said, well, we can't tell if this tumor is, active or not active, if the chemo got it or not. They saw spots on my spine at the different, 2 or 3 different places and then in my ribs, but they said from the bone scan they can't tell, if it's, what's going on, if it's active tumor or not.
Well,
yeah.
hold on a second. Let's back up a little bit. Sperling caught the bone metastasis on an MRI.
At 3T MRI.
Yeah, and he took a sample way back then.
Right.
And found it positive. So there was, low grade finding of bone metastasis right after the focal therapy.
Was that before chemo, Peter, or after chemo?
It was way before chemo. It was when he had his focal therapy in Florida.
Okay, so here's the thing that we're driving at. If the technetium bone scan is inconclusive, then it may be possible to get the darolutamide, even though we know you have the bone mets. That was Len's situation.
So how do you, what kind of bone scan is it? How do you say that?
Technetium.
How do you spell that?
T-E, I got to write it down.
Technetium.
All right, start over.
Technetium. Technetium 99.
Much better if I can get familiar with the way you talk. I need your permission to help.
So well, I'm going to put it in the chat window for you. But there's a sort of a loophole here, that if you are non-metastatic, castrate resistant, then you are eligible for darolutamide. But the way they define non-metastatic is through a technetium 99 bone scan. So even though we know the PSMA has shown that you have bone mets, if the technetium-99 scan was inconclusive, and the report said that, it may be sufficient for Bono to prescribe darolutamide.
Okay. Yeah, that's
okay.
Sounds like a try. Give it a try.
And you need to tell her. Be sure to remind her. Ask her about darolutamide and, as Larry said, enzalutamide. But be sure to remind her that you had an inconclusive bone scan.
Okay. All right.
Technetium-99. Do you think she could get you darolutamide? Because you may do much better on the darolutamide. It has, Len, didn't you do a post that showed that it wasn't just the fatigue, it had less side effects all the way around?
Yes, it did. But I think the other side effects were of less significance, like there was less rash. The big thing was fatigue. That was the big distinguishing factor between darolutamide and both enzalutamide and apalutamide or Erleada.
Do you remember if it said that comparison included nausea?
I don't recall.
Okay.
Possibly less nausea.
But it's in our blog. So if you go to our blog and you put in darolutamide, it should bring it right up, Jim.
All right. Yeah. I'll check. I'll get some homework done tonight before I call, so I know what I'm talking about.
Okay. We got to keep moving along because we want to get to Jay and we want to talk to Peter. So
yeah. Thank you. You bet.
Jim, thanks.
That helps.
I'm so glad you were on the call, and I'm glad we've given you some pointers. And keep talking to Peter. And if Peter needs to access Len or myself, we're available for you or anybody
Sounds
else
great.
that's on.
Thanks a lot.
Hey, Rick. Let me just throw this out there. I just found this from the Aramis trial. It says darolutamide was not associated with a higher incidence of seizures, falls, fractures, cognitive disorder, or hypertension than placebo. So those were the side effects that were less with darolutamide, and no difference between darolutamide and placebo. And both enzalutamide and apalutamide have higher incidence of those side effects than placebo.
So just repeat those side effects again, please, Len.
Seizures, falls, fractures, cognitive disorder, and hypertension.
Thanks. Thank you. Okay. Well, I think we've given you some marching orders, Jim, and you and Peter together can work on this, and then hopefully tomorrow you can try and see what you can do.
All right. So sounds good. Thank you.
Were you able to stand up on your board when you got out there?
Not too well. I caught one wave in an hour. I missed a whole bunch, and then I got one. Then I came in, but I was on the water.
Good for you. One's better than nothing.
Yeah.
And Len has posted in the chat window for you these seizures, these side effects. Let's visit with Jay. So Jay, tell us what's going on. I don't think I was aware that you did a PSMA scan, but I might be. I've got to pull up my notes. But bring us up to date, Mr. Mills, please.
Yeah, well, the PSMA scan was early on. It was before I before I decided to do radiation versus surgery, and it was before I went on ADT, and I had actually gone to Quan to say, help me with this decision of surgery versus radiation, and he didn't help at all, because he said, well, first thing, you're going to get both, but before you do that, you're going to get docetaxel. And so that was that's how helpful he was. And so, but he did, I did ask him, I said, I wanted to get a PSMA, and he sent me to UCLA, wrote a script for me to go to UCLA, and I had the gallium-68 there, and it said that I had nothing definitive, but there were two suspicious spots. One was something near my prostate, very small, and they thought was likely a lymph node, and then the other was just a suspicious area on the third rib on the right side.
Right.
And so when I did have my radiation, Shu expanded his. It was too close to the bowel to do anything with SBRT, so Shu expanded his HDR to include that area in the near the prostate, and then the rib. After I finished my 5 weeks of IMRT following HDR, Mac Roach did 3 sessions, I believe it was, of SBRT to that third rib.
Oh, okay.
So that was what happened with my PSMA. Okay. And the really interesting part about that was that all the radiologists at UCSF couldn't see what the guys at UCLA were talking about. And they went, and Mac Roach said, go back and look at it again. They all went back and passed it around, and nobody could find what the guys at UCLA were talking about. So then they contacted the guys at UCLA, and I think got coordinates or something. And he said, okay, we got something to go with now. And so they used that. I need to find out what happened on that. But that was actually reassuring to me that it was not that clear. It was just something that somebody thought they saw, which that's what it sounds like. Then
where did you say you did the PSMA scan?
UCLA.
Oh, UCLA. Okay.
And then where I am now is I'm sort of entering the home stretch on my ADT. I just crossed 18 months, and I had my 18 about 3 weeks ago. 18 of monthly Daguerreotypes shots. And my 18th one about 3 weeks ago, and about 4 or 5 months ago, I added on abiraterone. The Daguerreotypes had brought it down to a certain level. I can't remember where it was. And then I'd been considering doing docetaxel, but it ended up the studies showed last spring that was not an effective upfront adjuvant thing to do. But that abiraterone was. So I decided I would do abiraterone. When to start? I put it off for a while, and then I started again about halfway through my treatment, ADT treatment. And so I'm about 4 months, 5 months on abiraterone as well. And have the first guy I went to said you should do your ADT for the guy who put me on ADT was Brad Stitch at Mayo, and he said you should do it for 12 months. And
Can't hear you anymore, Jay.
Yeah, I wasn't sure if it was me or if it's. Yeah, we lost you, Jay.
Oh, sorry. There you go. Let's see. 1 second. I was talking on earbuds, and now my phone is changed. Let me check the battery.
Yeah, we can
5%.
barely hear you.
Okay. How's that?
That's
Is
better.
that better?
That's good.
Yes.
Okay. Anyway,
So you
I'm
said
on
we had you up to where you said Stish was going to put you on 12 months of ADT.
Yeah.
But then
That's
I'm
right,
sure that
right.
Mac wanted you to do 28 months, right?
He said 24.
24.
And
Okay.
he may have said if not longer. I can imagine Matt saying that. My local oncologist, a medical oncologist named Ted Aerosmith, who's been administering this for me, is he said that he's. I asked him about the Canadian studies and what he thought of the 18 months, and because outside survival, that's what it would be about. And he said he's for high risk. He said he would be for 24, if not 30. So that's where he stands. And again, being cautious. That would be what you'd expect from most medical oncologists, I think. That
what
the
is
larger study.
what's your current PSA? I mean, I've got PSA numbers for you at around 0.16, 0.14. I mean, what's the most recent PSA reading?
The last two were the same, 0.03.
So less than point. So you are now down to less than 0.1.
Oh yeah, down to 0.03. When I'd gotten down to around, I'm thinking around. Well, I need to go back and look, but it went down about 5 months ago, and then it was starting to tail out. Was my perception, and then I went and said, okay, put the clamp on. Let's go ahead and do that. Abiraterone. Put that on, and then it has then started having every time until the last two times, and it's just flat. It's 0.03.
Okay, well, I mean that's good. I mean, I think you need to get it at less than 0.1 for as long as you can. And is your plan now to stay on the hormone therapy, including the abiraterone, for a while longer, for the full 2 years?
I'm studying it to try to understand what the where that balance is. Is it that you have once you can't get it to go any further, have you done what you can do? And is it best to stay on both drugs or come off of one? Given
well, let me say this. I mean, I think there are very few people that I know of that have done both drugs as adjuvant therapy the way you are. So that's a pretty unusual treatment to be doing HT, to be doing an LHRH plus abiraterone for somebody who is on adjuvant therapy is unusual. And I know that when I did it, I'm not even sure the abiraterone was FDA approved. It was still in trial. In fact, I know it was still in trial. So I don't know that you're going to find anything definitive. What I will say, however, is that, and this is purely my own opinion, but I am absolutely convinced that it makes a difference to get that PSA down to less than 0.1, which is where you are right now, and to hold it at that level for as long as you can tolerate it. up to
Well, that would be
24 to
forever, I
30
guess,
months.
wouldn't it be? That would be
No,
forever. You just stay on forever.
no,
As
no,
long
for
as you can
20,
tolerate it. As long as you can
I
tolerate
said
it.
for as long as you can tolerate it for up to 24 to 30 months. So once you've got
Anyway,
it down there,
Mhm.
go ahead.
One question I have is that once it's down, what benefit is there to continuing to hold it down? I mean, how long is it? I don't know of any.
Right. Well, if you were to, I mean, I actually asked Mac the question because the 18 months versus 36 months came out whilst I was on my treatment. And I wrote to Mac or called him up and I said, Mac, look, there's this new study. Can I come off right now? And he said, we don't know. We said, we don't know if 18 months or 24 months or 36 months. He said, we to be honest, we really don't know. Now, the only thing that I'm basing my own personal opinion on is that when I've seen men come off the drugs too early, they relapse. And the guys that stick it out don't relapse.
Well, and that's ipso facto. That's the definition of too early.
Say that again.
It's circular logic. I mean, if you come off it and you have a relapse, they did come off of it too early, you could say.
You know, it's purely anecdotal, but I've seen it happen enough times that I am very glad that I stayed on the hormone therapy for 28 months. I'm not saying that it's the same for you or for anybody else, but I stayed on it for 28 months and I had pretty serious disease and I've had a durable remission. Now, as you know, my PSA rose for a year after I came off. And Matt kept saying, it's going to go down, it's going to go down. And it did go down, but it was 12 months afterwards. So, you know, you can't even expect to see it come down right away. But if it were me, I'd stay on it for the program, which was somewhere between 24 and 30 months. That's what I would do. Anybody else want to comment on that to sort of give Jay your opinion to help him navigate this? No other opinions?
No, sorry, I was muted. Sorry, guys, I know it's late. But Jay, I don't understand something. You mentioned that the your oncologist said you're not a candidate for for docetaxel for doing chemo.
Right.
Well, did he say
Well,
why?
actually, yeah, one of them did. He said that the data's not out, but our hunch is that when we do meta-analysis, we will see that there are populations, especially if you're young, is what they thought, I think, that it will be of benefit. And he said, but we won't know for 6 months. And by the time I had gotten my radiation treatment and put off the decision to go on docetaxel for a number of months, the study came out, the analysis, that said that it was not beneficial to do adjuvant docetaxel along with ADT, the radiation. And so that answered that question for me. There's not an outside survival benefit. There is, however, with taking adjuvant abiraterone. So I've gone on to abiraterone instead of going on it initially. Though I've gone on to it about halfway through my treatment of my ADT course. So
thank you for that.
So I'm sort of out of bounds, but lagging behind on that. So, but it has driven my PSA down further, which is great. Gives me more time at least.
Yeah, I know recently they've said that instead of starting with early docetaxel, that abiraterone is a very reasonable alternative to skip it. Len, you're muted.
Go ahead, Len. You were muted before.
No, I'm sorry, guys. I deliberately muted myself because I was talking into my phone.
Oh, okay. We thought you were talking to us. We're offended.
I had already spoken to Jay on the phone this evening, and so he knows my opinion already.
What is your opinion?
That since the conversation we had was in the context of concern about retaining, hold on, concern about preserving sexual function, recovering testosterone, things like that, quality of life. So, well, obviously, as you know, Rick, what my choice would be is the choice I made, which was to go on drug holiday. And my PSA was even higher than Jay's is right now. I think Jay's coming from this point of view. He's saying, hey, look, if I'm at 0.03 and it seems to be stuck there, why should I bother continuing ADT? For all we know, that residual PSA could be a few cells that were not normal prostate cancer cells that were not destroyed by the radiation, or they could be resistant cells. If they're resistant to ADT, then taking more ADT is not going to make any difference. Meanwhile, if he got off the ADT, he could at least recover sexual function, recover testosterone, prevent osteoporosis, rebuild muscle, etc. So that's kind of.
In the interest of time, let me stop you. It's not comparable. Your situation and Jay's situation are not comparable. You were diagnosed metastatic. Jay was diagnosed with locally advanced disease, and he had the same chance like I did for a continuing durable remission. His is not intermittent. Intermittent hormone therapy should not be in the vocabulary of this discussion, because he's doing hormone therapy right now in the hope that he'll never have to do anything again. And so it's a different ball game. It's a different ball game. You were diagnosed T4.
Yeah.
And Jay was diagnosed T3, as I was. And that makes it completely different. And so we're hoping that Jay's treatment choice of radiation and IMRT plus HDR plus however long he decides to do, again, to give him a durable remission, and he's never going to have to do anything again.
Well, Jay did say he had metastatic rib lesion, which he cured with SBRT.
No, he wasn't sure. They weren't sure. They couldn't really tell.
Oh, okay. So they weren't sure, but metastatic, but they zapped it anyway.
That's right.
Yep,
that's exactly right.
Yeah, and it's interesting. So in terms of certain things, everybody treats it, certain things because it was seen, because I was treated. A lot of, the medical world treats it as if I were, but then at the same time they treat it as if I'm not. So it's interesting. But it all comes back to that I'm in the home stretch, and I'm looking at that Canadian study that's saying 18 months adds versus 24 doesn't make any difference in terms of your outside survival. It adds maybe 3 months to, I think it was 3 point something months to the recurrence. And so 6 months of additional ADT buys you 3 months of recurrent till recurrence. That doesn't sound like a smart idea. On the other hand, it's an underpowered study, and that unfortunately there have been no large, really good studies that do any fine grain between, I can't remember if it's 4 or 6 months and 24 or 30 months, something like that. These large differences, nothing that deals with the 18 months, other than that one study of 600 patients in Canada.
And I think that was 18 versus 36, if I'm not mistaken.
That's right. That's right. 1836.
That was 18 versus 36. But I mean, I got to tell you the same thing that probably Mac would tell you. Stick it out.
Well, I know what Mac would say. I've asked Mac. I've talked to Mac.
It ain't worth it. You know, you've gone this far. Stick it out for another 6 months, and and then back. Did you talk to Mac? What did he say?
Before Mac said I would definitely do 24 months.
Yeah. Anyway, look, guys, it's late. I really wanted to get to Peter, but Peter, I'm so sorry.
Go ahead.
We'll have to do. Can we defer you until for an update until next week, next Tuesday, next Monday?
Yeah, possibly. I don't know what my schedule is going to be next Monday, but it's possible. If not, we'll catch up at some point. It's not that important.
Peter, did you have anything you wanted to run past everybody that's urgent?
No, nothing urgent. I talked to the Bayer nurses today, and they're shipping out the Beckwith to me this week. Finally got through to them. Yeah, it's just you got to stay on top of these things. You can't just leave things for your doctor. You got to be your own advocate. So I was on the phone with Bayer today. I was on the phone with my doc. I'm just following up.
When you say you're on the phone with the Bayer nurses in order to get your 2 months free supply, is that what we're talking about?
They had a phone number that was 5 years old from when I used to work. It was so bad. I mean, they claimed they tried to call me, and of course I didn't answer that number. And then they told me I wasn't eligible for coverage because the insurance they had was in California, and I don't have insurance in California. Anyway, you got to stay on top of these things. It's kind of crazy making. Yeah. Anyway,
let me give you a call afterwards, because maybe we can lever our Bayer contacts too. And also, it's good to know.
I got it straight. I think I got it straightened out. I just anyway, we're moving ahead.
Okay. All right. Well, I'll talk with you pretty soon, and maybe by next week you can give us a full update.
Yeah. Generally, I'm feeling pretty good. Yeah. Things are going.
Okay. You sound good.
Yeah.
You sound good.
Yeah. So
the
big New Year's Eve message for you guys is never squirt Colgate toothpaste in your eye.
What happens? Burns like hell?
Oh yeah, it made me blind for about half an hour. Yeah, it's pretty damn intense. That's where I was just now at the eye doctor.
Oh. Did you flush it with water right away?
Oh, I did, but a week later, and I can still feel it. Yeah, it's crazy.
Amazing.
Did you do that, or did one of your grandkids do that?
I did it. I don't know how I did it.
Sounds pretty hard to do.
I know.
I'm so sorry to. I'm so sorry to hear that. Peter, I'm going to call you. I'll call you as soon as we hang up because I'm not hearing you that well right now. So I'll give you a buzz.
Okay, have a nice fun.
As soon as we hang up. Okay. And
Happy New Year, guys.
Yeah, I wish everybody a happy New Year and
Happy New Year, everyone.
we're back regular schedule. I think the first meeting of the year is on the 6th. It'll be, I guess, a week from today. We'll be meeting, and Peter will have pride of place in that meeting.
It's like Yom Kippur. I mean, here we are going to a new year. It was another year in the book of life.
That's right. Yes, may everybody be well inscribed. Okay, Happy New Year, and I hope it brings for everybody on the call and anybody listening to the recording, I hope it brings lots and lots of good health to you. I really do. Okay.
Second that motion.
Right, and Jay, if you want to, you want to talk to me, give me a call.
We'll do it. We'll talk to you soon.
Okay. All right. Good night, everybody.
Good night, guys.
Good night.
Good night. Good night.